Good afternoon, everyone, or morning, depending on your time zone. Welcome to the January 2025 Quarterly Arkansas All-Payer Claims Database Data Users Group, or APCD, right? This is our 22nd one. We started this in 2015 or 16. It's been a great journey. My name is Kenley Money. I'm with the Arkansas Center for Health Improvement, or ACHI, ACHI. And my teams manage the data assets here at ACHI, including the Arkansas Healthcare Transparency Initiative, which is the overarching data umbrella that includes the Arkansas All-Payer Claims Database. Excuse me, I'm trying to move forward. There we go. Today's agenda was developed using data user input. If you have ideas for topics, please let us know. You can enter the ideas, questions in the chat, or you can email us. We're going to give you an avenue for that at the end. And perhaps they'll be on a future data user group agenda. So today's agenda is there's an introduction, then a demonstration of healthcare data dashboards. We have two to show you today that were built using the data from the HTI and the APCD. Some data user questions from other APCDs, the latest Arkansas APCD release information and data tips. And then we're going to have a survey that asks a few questions. We haven't had a survey in a while. We always welcome feedback from our data users. That's how we grow and get better. Some housekeeping before we move forward. Feel free to type your questions in the chat at any time and we'll address them as we can. If I miss them, my team will alert me and we won't miss them, I can assure you. At the end of today's session, we will provide a link to our service desk application where you can enter any question or topic you're interested in discussing. Arkansas APCD data can be very complicated. You could also request time with our team to ask and answer specific questions you may have about how to use and interpret the data. I participated in a very helpful call last week with a data user that was new to the data and introduced them to all of our data our user assets, and this person was able to begin their project much quicker because of that. The link to this deck will be provided in a follow-up email following this session. It'll probably be today, it may be tomorrow, but this link will take you to the repository of all the decks and recordings of previous data users groups. It could be that you have a question that we've already answered, and I encourage you to go out to this particular site, the link that's in the email you'll receive, and review the data user groups that are out there. The agendas are posted so you don't have to go into the deck to actually see them. Hopefully it'll help you find your subject area more quickly. But the answer might be there and it's a great resource. Hopefully we'll have some time at the end. We can open up to questions and ideas for future data users group topics or revisit things we've discussed. The presenters today are me, Kenley Money. I'm the Director of Information Systems Architecture and the APCD Director here at ACHI, and Kane Farnham, who is the Senior Data Visualization Analyst at ACHI. I can see we have a few new participants. There's some names here I'm not familiar with. So let's begin. Before we talk about our dashboards and invite Kane to speak, let's talk about ACHI just a bit to help provide some context for what we're doing in the Healthcare Transparency Initiative. So the Arkansas Center for Health Improvement administers the APCD and the HTI, the initiative. We were established in 1998, creating a much needed intersection between research and policy. ACHI is a nonpartisan independent health policy center dedicated to improving the health of Arkansans with proven experience in the management and integration of health data to support said research. Our mission, vision, and values are very data-centric and Arkansas health-centric. Our mission is to be a catalyst for improving the health of Arkansans through evidence-based research, which is one of the reasons why we have our Healthcare Transparency Initiative. Our vision is to be a trusted policy leader committed to innovations that improve the health of Arkansans and values trust, innovation, initiative, and commitment. And with all that, We are the administrator of the Arkansas Healthcare Transparency Initiative. It began through Act 1233 of 2015, which created it, the HTI, and it has become the premier resource for administrative health data available for research and analysis in the state. It mandates the creation and management of the APCD for fully insured claims. The Arkansas Insurance Department is the authority over it. They're the ones who set policy and rules, do the agreements, manage the money, and ACHI is, for all intents and purposes, the vendor. We are the administrator of it. However, the ACHI analytic team is arguably one of the biggest users of said data, though we have many, many data users that use the data a lot. The HTI integrates health data for many reasons. And these reasons are the foundation of many of the project questions that it's used to address today. Increase healthcare transparency, address cost, quality, utilization, support state health system transformation. And the magic that makes this happen is the type of data that's contained within it. It contains the all payer claims database, which has all of the insured claims. We have the fully insured claims for Arkansas residents, Arkansas Medicaid, Arkansas Medicare fee-for-service, the state employee data, which includes public school teachers and state employees, and other sources. And overall, we have line of sight on about 80% of Arkansans, making it a very robust data asset. So that is our introduction to ACHI and the Transparency Initiative. So let's look at a couple of dashboards that we have developed, that ACHI developed using said data. And I want to introduce Kane Farnham to give us a demonstration of these dashboards. I'm going to stop sharing and let him share his screen as part of this call so he can take us through them. Kane, I'm going to stop sharing.
All right, great. All right, thank you, Kinley. As Kinley mentioned, my name is Kane Farnham. I'm the Senior Data Visualization Analyst here at ACHI. I work on the analytic team, which, as Kinley mentioned, uses the APCD to help answer some of the questions that we want to further the health of Arkansans from a policy standpoint. I'm going to share two dashboards with you today that use the APCD. The first of which you can see on the screen is the Arkansas Healthcare Expenditures Dashboard. I'll give a brief overview of what this dashboard contains and how we arrived to this data. First and foremost, I want to point out that this information uses all four components of the APCD, the member enrollment records, medical, pharmacy, and dental claims. This dashboard contains all individuals that had 1 month of enrollment for the given time period. We're looking at 3 years, 2021, 2022, and 2023. So for all members enrolled in the APCD across that time period, for 2021, we have 2.6 million individuals. So we're capturing the vast majority of Arkansans with the member enrollment records. Those individuals that were enrolled within 1 month, or with at least 1 month, the sum of their medical, pharmacy, and dental paid amount costs from their claims is $25.2 billion for 2021. And to standardize those costs across individuals and the total amount of coverage they had in a given year, we've created an average annualized expenditure metric that you can see is almost $12,000 for the year 2021. If I can bring your attention over to the left-hand blue banner portion of the dashboard, this dashboard captures those three metrics that I just mentioned, the individuals, the total expenditures, and the average annualized expenditures. And we can toggle between those measures here for what the rest of the dashboard displays. As I mentioned, we have 3 years of data, 2021 to 2023. And we can also split out the different types of coverages that the individuals were utilizing, whether it's all three, medical, pharmacy, or dental. And for the medical type of coverage, we've broken out their claims by service type. We've classified those as outpatient, emergency department, inpatient, nursing home, and other. So the largest measures that we have are at the top. They're the aggregate across the entire state. However, beneath that, you can see we have all of these measures broken out by demographic. We have sex, age group, race and ethnicity, payer type, and county as well. And this is the filter that toggles what measure it displays at any point in time. So here you can see that of those 2.6 million, 1.4 million are female, 1.3 are male. We have our age breakout, with 19 and under being the largest scope of ages. You can see that one, just almost 700,000. Every other age group is pretty standardized to 10-year spans, so they're pretty consistent. Race and ethnicity, and then on the right-hand side, we have our payer type and county. Again, this is number of individuals, so you can see that Pulaski County and Northwest Arkansas kind of stick out here as far as total population of those counties. But these filters on the left actually work in conjunction with these demographic graphs as well. For instance, if I wanted to know the total expenditures or average annualized expenditures for only the female population, I can select females within the dashboard, and you can see that the dashboard updates to reflect only those individuals that are female from their member enrollment records. We can narrow down even further. If I were interested in females that were 25 to 34, we can select that demographic as well. And you can see that those females 25 to 34 for the year 2021, their average annualized expenditures across all three types of coverages is nearly $8,000. And if we can drill further down, just see what their medical is, 6301, the vast majority of that total. And if I want to know the payer breakout of those, but the actual average annualized expenditures, we can toggle this choose measure. And now you can see that the distribution, even though it's 6,300, is varying across payer types. Of course, if we have individuals enrolled in Medicare at that age, 25 to 34, they're likely high utilizers in the healthcare system. So you can see that their average annualized expenditures is over $12,000. And then now that we're on a standardized metric here, the average annualized expenditures, the county map updates to show that, and we can glean more analyses from this that's not just how big the county is. So for instance, Newton County has the largest average annualized expenditure for that demographic group across the state. And the minimum is about 5,000. So pretty tight knit amounts there for this specific demographic. And then in using the filters within the dashboard, we have an option here to just reset the filters in the view. This is required such that we can get back to our 2.6 million enrollees. Still just loading here. Okay, so I've reset the dashboard. As I mentioned, we can view these data across time. We were looking at 2021. However, that year specifically, we know that we have some COVID impact in the healthcare utilization. That is, however, the only year that we have Medicare fee-for-service before. So we kind of honed in on Medicare fee-for-service a brief moment there in the payer type graphic. However, in 2022 and 2023, we don't have Medicare fee-for-service data yet cleaned for this dashboard, so that'll be a future update. That's the function of the dashboard. Kinley's obviously going to provide a link such that this dashboard can be explored on your own time. The only other thing I'll point out real quick is that the button down here about the data goes into some of the more details about what is an outpatient visit, what's an ER visit, and includes just some further methodologies, as well as beneath the dashboard, there's another about the data section that contains some of the same information. Before I go on to a secondary dashboard, if there's any specific questions regarding our healthcare expenditures dashboard, I could take those now, or we could come back later. My chat window is hidden somewhere along the
I don't
many
see any
pages I
Kane.
have. Okay, great. I will move on to our second dashboard. This dashboard is titled the Arkansas Acute Behavioral Health Events Dashboard and is a subset of the APCD population. We gathered all individuals that had medical claims with a behavioral health diagnoses using the ICD-10 CCSR categories. So we're not looking at the entire population, just those individuals. This first window here simply captures the number of patients and encounters that those patients had for those specific diagnoses in the ED or the inpatient setting. So similar to the last dashboard, on the left-hand side, you can see a few filters. As of right now, we're looking at all 3 years contained within the dashboard, 2020 to 2022. For encounter type, we're looking at ED visits. The diagnoses group here in behavioral health, we've subset these out into 2 different categories, mental health and substance use. For the majority of the demonstration, I'll just leave that on all. We have a measures filter that allows us to look at distinct patients versus total number of encounters. And then in this view, just because there's quite a few, well, there's just fewer individuals that we're looking at. Sometimes county level analyses isn't necessarily fruitful because there's so few individuals in rural counties. We've included a regional look, and then you can toggle to county for the county map to become more granular. So with those filters set the way they are, if we just take a quick look at what the data contains, we had nearly 57,000 individuals seen in the ED for one of those ICD-10 diagnoses codes. Of course, by region, we could expect that the central region has the most. We have the breakout by sex, by age group, and again, by payer type. And this view is really to give context for the 2 views that we'll discuss. The first of which is called recurring encounters. So to kind of give an idea of what the storyline is for a given individual, if an individual is seen in the emergency department for a behavioral health event, we want to know whether that individual was back in the ED within 30 days or if they were not back into the ED within 30 days. So recurring encounters right now, I've set the initial encounter type to be ED visits. So these are still those 59,000 individuals or 58,000 individuals. And I've set the recurring encounter type to ED visit. So for the entirety of the 3-year span, 2020 to 2022, 22.8% of all ED visits had a follow-up ED visit within 30 days. So we'd like to see this number going down. We can see those breakouts by sex and age group. The males are at 27.5, so contributing quite a bit to that recurring encounter rate. And then as you look at the age groups, as you get older, you're more likely to be seen in the ED within 30 days. One thing to note here is that we don't have Medicare Advantage, or excuse me, Medicare fee-for-service isn't available in this dashboard as of yet. So though it looks like 65 plus is down at 14.2%, that's not reflective of all 65 and up individuals in the state. The other encounter types, I mentioned we have inpatient stay. We can toggle to inpatient stay to see how often they are readmitted within 30 days. And for the statewide 2020 to 2022 time period, that is 19%. So if you're seen, or rather if you're hospitalized for behavioral health diagnoses within 30 days, 19% of those individuals are hospitalized again. And then our last tab we have for the acute behavioral health dashboard is the outpatient visits tab. This is specifically outpatient visits that occurred after one of these acute behavioral health events, the ED or the IP or the inpatient stay. So on the left-hand side, our filters just slightly change. Now we're looking at follow-up visits. We have the option to look at prior visits as well, but I'm going to hone in on follow-up visits for the time being. We can also look at a time frame for that follow-up visit. So the shortest time period we have is 7 days. So if we look at the entire state at the top, if you were seen in the emergency room for a behavioral health diagnosis, only 16.7% of individuals had a follow-up within 7 days. And then to kind of continue looking further out, moving that time frame to 30 days, we can see that it's 30% of individuals had a follow-up. And this is the HEDIS recommended window of time to have a follow-up. It's 30 days. So at 60 days, that number climbs to 36.9%. At 90 days, it's 40.9%. And then the furthest window we can look out is 120 days. So at 120 days, only 44.0% of people are getting a follow-up outpatient visit. And that outpatient visit just is for a behavioral health event or for a behavioral health diagnosis. It's not any outpatient. And you can see the breakout here at 120 days. There's very clearly some groups that are performing better than others, specifically children 6 to 12, they're up to 66.2%. From a payer standpoint, Medicaid Pass, which is very specifically Medicaid specific programs for those individuals who have behavioral health diagnoses, they're at 77%, which is expected. And then if we look at the geographic view, I'll go down to county just so we can see more variation. It appears that Searcy County has a 69.3% follow-up rate. Plenty of counties you can see are tinted red, which means they're less than 50. And then the one last thing I'll mention about the outpatients view is I mentioned earlier we have a prior visit option. This just moves the window to look for outpatient visits to prior to their acute behavioral health event, whether it's ED or IP. So if we look at 30 days, for instance, this is saying that of those individuals that had an emergency department behavioral health visit, only 20.4% of them had a outpatient visit within 30 days prior to that event. And then similar to the last dashboard, we have a more detailed explanation of what gets you in to the dashboard, what data are included or excluded, and there's a by view breakdown of the measures that are included, as well as the demographics. And it has its own webpage below as well. I'll open up to questions about this dashboard or both dashboards.
Okay,
Or if there's any,
there were 2 questions in the chat.
great.
And I'll take the first one and you can help with the second. The first one is, what are the reasons for these 2 dashboards? If we have ideas for dashboards, can we suggest them? These 2 dashboards had external funding and were requested specifically, which is why we have them. And if you have ideas for dashboards, you can certainly share them. However, we would have to work out. I mean, I can't say we could do them free of charge, but perhaps that there's a path that we can do that. And so, Kane, can you see the second question in the chat?
I did, I managed to pull it up. So the question is, I did not see self-pay as a payer type in the first dashboard. Is it because the data was not readily available? So this question is more complicated to answer for the first dashboard in the sense that self-pay is included in the second dashboard because in the patients and encounters view, we wanted to be able to capture those individuals that were seen in the ED or IP for behavioral health diagnoses. However, we don't have line of sight on their entire claims. So though they're displayed here for completeness in the demographic overview, they are not displayed in the recurring encounters or outpatient visits. The simple answer is self-pay is not included in the APCD itself. It's rather included as a supplemental data source that Kinley mentioned early in the presentation under the HDI. And because of that, there's a lot less fields available for us to use. So because this dashboard was specifically looking at expenditures across the state, we didn't include the demographic breakout of the self-pay individuals. Though we could see the number of individuals utilizing with self-pay, we wouldn't be able to analyze them any further, particularly costs. So I hope that answers your question, but.
Does anyone else have any questions? Is there a particular scenario you would like Kane to demonstrate? Again, you'll receive the links to these in your email, so you'll be able to go out and illustrate whatever scenario you would like. So Kane, if you will unshare, I will reshare. Okay. Screen 2. All right. Is everyone able to see the screen that says demonstration of the latest healthcare dashboards? Yes. Yes.
Yeah,
okay.
we're all good.
When you get the copy of the deck, this is what you'll see, and you'll see the link is in red there. So you can click on the link for either of these dashboards and go do additional reading or play with them. So thank you, Kane. I appreciate it very much. The next section we're going to review quickly is called Data User Questions from Other APCDs. There are 26 or 27 states with an all-payer claims database. Most of them look fairly similar. Differences between them are largely based on, aside from state regulation, the population base. One of the APCDs I like to use for these questions is Massachusetts. They have a very robust data users group. And every month or 6 weeks, they have a meeting and produce great documentation and decks. So if you're ever interested and you can't find an answer to a question you may have on our site, it wouldn't hurt to go out to the Massachusetts APCD site. You might be able to get some information over there. So the first question that we're going to talk about that I found interesting is this is directly from their deck on their site. Does the Massachusetts APCD contain data on prison healthcare? And they go into their 2 slides here. they go into the two types of data elements that they use to find these types of claims. Massachusetts uses a place of service field, MC037. I believe we call it facility type. It's the same field, MC037. And in Massachusetts, there's a value 09 that is used for prison, jail, reformatory, work farm, detention center, etc., that type of facility. And then the other thing they use is a taxonomy code. In theirs is MC032, and it is a specialty-like code, and you can see the 5 bullets there that it represents. So Massachusetts uses these two data elements to mine for data on prison healthcare. Unfortunately, as I said, every state is different. We do not have the facility type in Arkansas, but we do have some claims that have that taxonomy code. And I just included for your information some very high level counts. There are very few restrictions on these counts, save the year, and they just represent distinct claim by service year. These counts are not answering any analytic question except to show that there's some claims out there with the taxonomy code that represents prison-like healthcare. So if you have an analytic question that requires that particular type of information, this might be helpful to you. The next question that, again, I lifted from Massachusetts was managing overlapping data. And I'm not going to read this question to you. It is verbatim from the deck. I'm just going to summarize it. And the way this particular data requester got data from the Massachusetts APCD, this person got two or three big cuts of data that overlapped. I don't know what their question was. I don't know why they did it, but it can be related to some of the data distribution that we have. In their scenario, their data overlapped and they wanted help in knowing how to deduplicate it because of storage issues. They had a certain amount of space for their analytic environment, et cetera. So I use this question because some of our data users utilize data from a subscription. We have 2 big partners, 3 actually, that purchase a whole copy of the APCD, not just the extract that is related to their analytic question. And if you're using these data, these copies, and these partners, what they'll do is they get 2 cuts a year, and they'll keep 2 or 3 copies of their version of the APCD available to their data researchers. Because if you start asking your question on a copy 2 updates ago, you may not want to move. You may want to get the fresher data. There are lots of questions. But I did a little work, and just to get an idea of the overlap between the claims in these years of data, you can see here the blue circles represent the cut from the spring of 24, and the red circle or the salmon colored circles are the latest one. And there isn't a lot of overlap if you're using a subscription to look for data for your analytic question. So just be aware. And I say all this to say the following. If indeed your data request requires extracts from multiple builds, I'm going to stop here in one more tangent and say, sometimes I get a data request that says, give me all the data you have right now, and then give me new data later on. And it's in 2 parts or 3 parts. And sometimes there's overlap there too. But I say that if you request data that may be in pieces or from multiple builds, then work with the Arkansas APCD team to get through all of those nuances, because you don't need to deal with duplicate data, and you certainly don't want to use the storage. Storage is precious. So it's out there. Work with us. Probably very few of you will even need to worry about this, but we wanted to make certain that you knew it was available. Okay. The next section announces our latest build. The last time we had the data users group, which was in October, we didn't have fresh data, but we do now. So the current data available is through June 30, 2024. The last time it was December, we released data in 6-month increments. That's not to say that there isn't some newer data. For example, Arkansas Medicaid almost always has 3 more months of data. Their data is through September 30. And we include it anyway, but officially the cutoff you can see there is June 30. So these data are ready for data requesters to consume. We have fresh release notes, we have fresh universe counts, updated data dictionaries and tip sheets. One of the new things here is that there's a new PBM for the Arkansas Employee Benefits Division. That's the group, remember, that has the state and public school employees. A quick infographic just to give you a snapshot of the data that's available is right here. This is on the website. When you go to arkansasapcd.net, it's one of the first things that you'll see, but it illustrates the data that we have for the big file types, commercial, Medicaid, Medicare. Something else that's new, Kane talked about in his dashboards, they use data from Medicare fee-for-service through 2021. When the dashboards were being developed, that's all we had, but we now have I said Medicaid, I meant Medicare fee-for-service through 22. So if you are eligible to access Medicare data, know that you're going to have a new year of data available. And I believe that our analytic team will be updating the dashboards with the latest Medicare data at some point in the future. Not everyone is able to access Medicare fee-for-service data, but if you are, you have another year at your disposal. Also, now the health insurance claims that you just saw, that makes up the APCD, the All Payer Claims Database, but that which makes the supplemental data that we include with it under the Healthcare Transparency Initiative are these sources: birth certificate, death certificate data, emergency department hospital discharge, cancer registry, and medical marijuana card holders. We have more data from that too. So this is our latest update. I hope that that you are able to request data from it soon and it can address your most current analytic questions. I mentioned that we have fresh release notes. I put this in here. Sometimes a data user may not look at a release note, the release notes, and it has good information. A lot of times this is translated in a data tip, but we want to say the more you see it, the better. In this particular one, this is an example. We have a submitter, Health Smart, that had some malformed member IDs, carrier-specific unique member IDs, and it broke links between the enrollment data and the medical claims and the pharmacy claims. They wouldn't go together, but we worked with that submitter and we repaired all of that. And so you will get linkages now. So if you have data from an older data set, you probably need to go to the data tips to work through this, but in the data that is available now, this has been resolved. That is an example of how we use release notes and data tips. Always remember, check your data tips. We'll always say that. Okay. Oh, and the data tips, if you've been out there, you know, we have a lot of them, and we have undergone a project to clean them up, review them to ensure that they are still relevant. We're about halfway through, and some of the data tips have been updated. We've got links that are repaired and manuals that have been updated, and these data tips are the result of some of that. If you are not on the list, I would expect everyone here is, you need to sign up for our monthly data tip refresh email. Okay. So I promised
Webinar.
I promised us a survey, and I am going to share a screen, and I'm going to turn it over to my associate, Joshua Cook, to explain what we are doing. And after he gives instructions, I'll take us through the questions. Joshua, are you there?
I believe so, Kinley.
You believe
Thank
you're
you.
there? Okay. All right.
So yeah, Kinley's going to be bringing up a tool called Mentimeter, which is effectively an online interactive tool that allows you to give live input to questions and prompts. And we can collect all that so that we can better serve you and put together information that's most helpful going forward. So you'll see a website up on the screen and a code. If you can go in and plug in that on your computer or mobile device or whatever you have, and then Kinley will walk us through some of these prompts. And so everyone knows this works best when everyone participates and shares your input. That's what this is all about.
Thank you, Joshua. Appreciate it. So I'll give everyone just a moment, menti.com, and it's fairly straightforward. There's going to be a box and you enter this code. Okay, I see a thumbs up. Yes. 30 more seconds so everyone can get aligned. I appreciate the thumbs up, I really do. Okay. Okay. If you've been to our website or you've requested data from us before, we have a lot of user tools. A lot. There's a button on our website called Understanding the Data, and it has, I don't know, 20 different sources and things that data users can use to help cut through their data and understand. So this question is, what types of information are most helpful when choosing data for your project from the Healthcare Transparency Initiative, or the APCD? Our desire for these three questions, there are three of them, is to give you better tools. One of the challenges is, how do you even know what's out there, right, to ask for the data? So I take a moment, think about this. If you are going to request data from us, what do you want to know? Type in your answer, hit enter, and it will magically appear. I would also appreciate if you request data from other places, other APCDs or federal sites, CDC, CMS. What do they provide that? Thank you. Oh, good. Recurrent similar claims. Okay. So that makes me ask questions. Anybody else? I'll give you some more time. We've got time. Okay. No. Conditions. Okay, thank you. Condition specific detail. Very interesting. Universe. Thank you. Couple more. No. Okay. I want to give everyone an opportunity. Again, if you think of something else later on, you can reach out to us through email that we'll give you. All right, I'm going to move to the next one. What types of reports, user guides, tools, or other information would help shorten the time required to understand the data pulled for your project? And I ask this question because when we deliver data, whether it's a subscription or just a one-off project, we do provide some information, the quantity, the file type, links to our big website with data user tools. But if there's something that you would like or you've received from other organizations from which you got data that help you understand your data faster, we would be very interested, because that's our goal. We want you to be able to use your data faster. Oh. So many things to think about. I wonder if a possibility is if when you receive your data, well, I hate to give answer, but if you receive your data is an intro, there we go, is shorter time of virtue carry, okay. That's a very good question. So carrier member link, okay. Would one-on-one sessions help to take you through the data? Don't answer yes, just please write it. Thank you. That's very helpful. Rurality options, very helpful. Okay. All right, I'm gonna move on. No, okay. And our last question. So for those of you who have used data between builds, that have requested data from us more than once, and the later cut has got newer data in it, what types of information and counts are most useful to understand the differences between the builds? This probably is more appropriate for our subscription users. There we go. Thank you. Changes in member counts, yes. Total paid amounts, interesting, okay. Interesting. Changes, okay, yep. By half, subtotals by half, okay. Thank you. Unique members, okay. Great. Interesting. Okay. Recurring claim counts, okay. Again. Recurring claim. I like it. Okay. Okay. This is great. Thank you so much. Thank you. I am going to now stop sharing. And again, if you think of something else, then you are more than welcome to send us an email. Let me share my screen again. Screen 2. All right. Okay. Stand by. Okay. I want to get back to. Here we go. Okay. Great. Thank you very much. All right. My next slide is kind of similar for our April data users group webinar, and our next users group is April 23rd. We are asking for some additional feedback, and here's what's going on. The Arkansas APCD data submission begins with the insurance payer or insurance carrier. And these entities, Blue Cross Blue Shield, United Healthcare, Aetna, etc., they receive requirements in the form of a document called the Data Submission Guide, which is essentially the required layout for the data they're supposed to give us. And every carrier payer has to deliver data in the same layout. And when we receive the data, it triggers all sorts of automation and validation, et cetera, et cetera, et cetera. And then it is consumed, moved into the database build, which is largely what you see when you get data. The build itself, that which we pull data from for you, it's mostly unchanged from the data submission guide. Well, periodically, we have to update the data submission guide or add or take things out. And we don't do this very often, maybe once every 3 or 4 years. It's a very big process to do. But this year, we have to have a data submission guide change. And so I'm bringing it up here because in about a month, we're going to send out a note to this distribution list, all of you, and ask for some feedback, such as, and you see the bullet, what are we looking for? For example, in the data we have right now, required from the carriers through the data submission guide, on a medical claim, we have 13 ICD diagnosis codes and procedure codes. There's a primary for each diagnosis and procedure, and there are 12 supplementary. But the new standard is 25. There's the primary and 24 supplement for diagnosis and procedure. New APCDs that utilize the new common data layout get all of them, the 24. So our question to you do not have to answer now unless you want, would be, are the additional 12 beneficial? How valuable would they be? Another question, another example is that next to the last bullet that said the new best practice in APCDs across the country is not to collect the EIN or tax ID number for providers. And there isn't in the latest layouts for other APCDs, they don't collect it at all. We collected, it was a holdover from when APCDs really began. Are these fields used in your projects? Do you use EIN or tax ID number for providers? And then of course, the last ones, what other data elements would be helpful? So this is a teaser. You're going to get an email with some questions about what would be helpful, what don't you use. I can't say that everything will be incorporated because once we have proposed changes, there's a lot of review and approval that has to occur. But we want to give you the opportunity to provide some feedback. These data are for you, for the data users, and we want to make it the best ever. So if there are changes you want or new data elements, then this is the best time to do it. Timeline. We'll take all this feedback, we'll produce the new data submission guide, get the final approvals. It goes into publication in December, and the first data that we'll get from it that is ideally March of 26, but I can tell you from experience, carriers can't make changes that fast, so it'd probably be June. So it will be a while before you would see the changes that you request. But it's happening, and this is a great opportunity to help make this data more usable for you. Oh, I see a question. Let me see. Thank you. Standardized string acceptance. Oh, okay. Thank you, Shalise. We will take that into consideration, and I may reach out to you for some clarity. Okay. Thank you. Thank you. Appreciate it. Okay. We are closing in on the end. This is our technical support email. Again, this link will be in the deck that you can download, or you can just not note it here. This is the best way to communicate with us. A team of 3 or 4 sees this email box every single day. Send your ideas for future data user groups. There it is. And then call to action. If you don't have the ACHI newsletter, please sign up for it. Follow us on social media, and our next users group is April 23rd, 2025. And with that, I thank you all for coming. We look forward to hearing from you, and look for that, the email about the new data elements very soon. Thank you, everybody.